Okay, so it is my pleasure to welcome you all to the next session. This is Abstract Session 6. We have 4 talks, the first one 15 minutes, and then the next, which will be 5 minutes each. First up, we have John, who's coming from Canberra, is that right?
Yeah. Yeah.
Okay, so you got 15 minutes, and when you hear the sound, you'll know you've got 1 minute to go.
Sounds good. And you can hear me okay?
Yes.
Great.
Share your screen and take it away.
Cool. Thanks. Just. Can you see that?
Yes.
Great. Awesome. Okay. Thanks very much. And thank you very much to both of the societies, SSA and the NZ Society, for giving me the opportunity to talk. The project that I'll be talking a little bit about started in 2019, just after my PhD, when I was working in industry for the Australian Institute of Sport. And then I sort of drifted away to a postdoc fellowship at UNSW. They recontracted me back in, so I set up a small business for myself called J Squared Analytics, because you get exponentially just as much John as what you pay for, or something like that. And I'm about to start a new fellowship at UTS. So I'm sort of at the moment in between University of Canberra and UTS. But this particular project, even though it's taken many years to actually get to a point where we're writing up some papers and we have some results, is really focused on bringing the statistics and data science community and communities together with sport. And a part of the reason for this is that we traditionally in sport have had many people arguing with each other about using statistics, which perhaps isn't all that uncommon when looking at other areas. But just using a particular use case in 2006, a couple of physiologists came up with their own novel Bayesian-esque interpretation of what was essentially null hypothesis significance testing. And pretty quickly, people from the statistics community said, oh, you know, maybe don't do that. Maybe, you know, here's some other things that you could potentially consider if you're looking at some Bayesian interpretations. There were some more reviews because the community kept using these methods. They were very well publicized and disseminated through our community. And normally when it gets to this point, you know, when enough people have critiqued something, things generally start to slow down in terms of their use and application. But, you know, there were responses to responses, new people who got involved and started saying, perhaps, you know, you shouldn't be doing this, and it continued, and eventually it ended up in scientific comms and sort of scientific magazines, podcasts. If people are on Twitter, you know, fantastic. I know Twitter's on fire at the moment and most people have probably moved off it, but eventually it landed in mainstream sort of Fairfax media, so Sydney Morning Herald, Canberra Times, that type of stuff. And it's really unusual for sport, and particularly sports science, to be featuring in that space. But it was a unique opportunity to frame this project to the AIS leadership at the time, mainly built around one, sort of understanding what do people in sport actually want to do when it comes to analysing data for either research or practitioner purposes, and two, like I said, bringing those communities together. So the project had quite a big team of people, both in terms of people who come from a sports science and sports medicine background, and a lot of people from the statistics and data science communities internationally and domestically who I've either worked with or I'd sort of spoken to because they've worked in sport. So I'd like to acknowledge them for this talk. And we basically ran a survey that was iteratively designed through lots of testing and sort of workshops using design thinking that ended up landing on 4 particular areas of questions. So who are these sports scientists and sports medicine individuals that we are surveying from a demographic perspective? What types of data are they collecting? how are they using statistics at the moment, and can they give us some information around that from a software and from a knowledge perspective. And then also sort of looking into the future, like what are the constraints and pain points that they potentially see for being able to shift the dial on what they're doing at the moment moving forwards, or just in terms of connecting with these groups of people in statistics. And because there are a lot of questions in the survey, and I also have 10 minutes with the bell that you mentioned that will go off, I'll focus on a couple of the major insights that came out across a lot of the questions, and I'll give my email out at the end for people to ask a little bit more about this as well. Interestingly, we have in sport a weird sort of environment where at times, particularly in the high performance world, where the athlete groups that we're trying to access and analyse, we're sort of restricted to getting them in their sort of natural sporting environment. People end up often conflating what I would call the regular practitioner scientist uses of data and statistics, so that real-time decision making, that are collecting data on the fly and using information to, without writing anything up or publishing it, do something with an athlete or a squad. That can sometimes get conflated with that more traditional, we're going to set up a project strategically to basically make an assessment of whether or not a particular intervention works or not across a large group of people. And we're going to basically design a well-constructed experiment as a part of testing that concept. And because of that messiness, and also there's some issues with sort of assuming that things generalize very easily from athlete to athlete. There's some sort of subtle but weird nuance when it comes to using statistics in sport for either research or practice perspectives. And one of those is, as I was sort of alluding to with that issue of things generalizing, a very strong focus on individuals. So when we asked, there ended up being 106 people who responded to the survey across about 10 disciplines of sports science and sports medicine, with a lot of overlap between them. What purpose are you collecting data for? There was a large focus on things or items related to assessing change in an individual, or comparing specific individuals, or understanding an individual within a group. When you couple that with the fact that people are collecting a lot of time series data and repeated measures on these individuals over time, and they're also collecting it in what I'd call quite a naturalistic experimental environment. So it's the training environment where the athletes take place. There was a strong desire in terms of working with coaches and programs that information that we're collecting and the work that we're doing to generalize back into that environment for a specific athlete relative to something that we're looking at. Concept of meaningful change came up across a number of questions, and that was both in terms of giving evidence. So, we think about strategically how you might set up a research project to actually assess whether or not a recovery process like ice baths might work with athletes. And we have some reasonably well-founded research practices that we can stick to for designing good experiments for doing that. But that concept of meaningful change also carried through to, how can we be sure that the change that we saw from Tuesday to Wednesday, or the change that we saw at this particular time point after we introduced an intervention with an individual athlete, was actually meaningful. So that was a consistent theme that came up independent of area of sports science or sports medicine. And then not so surprisingly, but this is sort of something that I think people in particularly the statistics side of this project were interested in, because of the growth of a lot of software around interactive visualizations, the fact that visualizations help to bridge the gap in terms of data literacy and talking about data, concepts related to data exploration, everything from descriptive statistics, visualizing data, through to more traditional but multivariate exploratory methods like clustering and PCA, also featured across these questions. So I'm not going to keep going on the insights there, but what I want to say is that there was more, and I could probably talk a little bit more to that. But once we got all of the results, and we wrapped that up, I ended up having one-on-one, 1-hour conversations with each member of that statistics group on the project to think about, well, if this is sport, what does that mean for potentially working with statistics, and what could that look like? And already, interestingly, some great conversations and talking points emerged. So for individual monitoring, people from statistics were much more interested in, well, why are you monitoring in the first place? Are there particular targets or outcomes that you're interested in trying to get some type of likelihood of an event occurring, you know, at the end of it before you use that for decision making? Are you potentially looking at monitoring individuals relative to their normal bandwidth in terms of, you know, whether they're deviating from what's unexpected, from what's expected for them as they're being monitored over time? Are you monitoring because you actually want to project forwards and predict what's going to happen or forecast what's going to happen in the future for a particular outcome? Because depending on the purpose, all of these things look very different. And similarly, in sport, there has been a large focus on trying to identify the best way of defining the smallest worthwhile effect, so the magnitude of a meaningful effect. There was a great number of discussions that occurred in the space of, you know, is it also worthwhile to help people in sport start thinking more causally as a potential gateway to doing well-constructed, obviously with some guidance and connection with statistics, causal inference type studies, so that you can be sure that if you're looking causatively at whether or not something has an effect on something else, you know, you have some confidence around that. A large number of conversations also started to touch on the function of how this would actually happen. So the concept of communities of practice being potentially important for bringing those two groups of people together. That was from the perspective of connecting individuals. So connecting people in sport with people in statistics, and also looking at capability uplift. A part of the reason this is there was an opportunity potentially for data use cases in sport to help progress the state of the art for statistics, because those examples of data and those contexts might be practically useful for people in statistics. Look at framing tandem PhDs between people, PhD students in statistics and sport-based PhD students around a particular theme or data context. If you build a community of practice, we also have mechanisms for building a scalable, connected group of people working in data in sport. So everything from upskilled practitioners all the way through to specialised teams of experts with very specific expertise in areas of statistics that align with questions in sport. And the capability uplift bit was also something that was talked about, I guess, a little bit more intensively, because the volume of problems that we'd expect an upskilled practitioner or scientist could handle with some training would be more likely to be larger than, say, what you'd expect a specialist team to be looking at doing. But when we look at that, it sort of does cover off on both capability uplift and connection. And the last thing that I wanted to mention was, so we actually took this one step further. So recently, myself, I've supported Dr. Paul Wu and Professor Kerry Mangerson with a host of other people at QUT for a grant to the AIS to actually see if we can materialise this. So if we have the meat, which is like, you know, we know these areas of interest, individual monitoring, exploration, meaningful change exist in sport. And we wanted to build a place, some infrastructure for where these groups of people could come together or information could be housed. We've recently won an AIS grant for building what's called sports data science kiosk, like a Bunnings kiosk, where you go in and you basically ask for help and you say, I have this problem, except it's a digital space, probably built off the back of something like R-Shiny with a form and some classifications and tags that link the problem to particular software guidelines or training. And the only thing I was going to add relative to that, because it's a very new project and we haven't actually got it off the ground yet, we are about to look for a 12-month postdoc for that particular role. If you're interested in that particular project, feel free to email me at the moment. I've given my J-squared analytics email because I don't have a UTS one yet. But if you're interested in being connected to that community, if you're interested in the work that's taking place, feel free to reach out. And that's it. Thank you.
Thank you, John. We probably have time for maybe just one question. I don't see any in Slack, but if someone wants to unmute their mic and ask a quick question, otherwise we'll move on to the next. No? Okay, thank you, John.
That's okay, thanks.
Next up, we have Fiona McManus from the University of Melbourne. You ready to go, Fiona? Yep. Like before, I'll give you the 1 minute shaker. And you've got 1 minute to go. It's all yours.
How's all that going there?
Yep, I see it.
Okay, great. Out of the way. Fantastic. So, yes, good day, everyone. So, yes, I'm Fiona. I'm a physiotherapist turned biostatistician from the University of Melbourne. And today I'm presenting the study from myself and my colleagues at the Centre for Health, Exercise and Sports Medicine, titled "How Does Exercise with and Without Diet Improve Physical Function in Adults with Knee Osteoarthritis?" So this study was exploring potential mediators of effects. So the reason for this study was that there is limited understanding about the mechanisms by which exercise programs with and without diet work to improve physical function in adults with knee osteoarthritis. But if we can identify precise mechanisms of effect, we can target these in future treatment programs. And this in turn may enhance the effects of these programs. So using the PICO framework, our population were adults in Australia aged 45 to 81 years old with knee osteoarthritis. There were 2 active intervention groups, each a 6-month telehealth delivered exercise program, one without weight loss diet, which I'll refer to as the exercise group, and one with weight loss diet, which I'll refer to as the diet plus exercise group. The comparator group received access to a website with information about osteoarthritis, so this is our control group. The outcome was change at 12 months in physical function, measured by a self-report questionnaire called the WOMAC. Our study design was a secondary or exploratory analysis of a randomized controlled trial. And the 6 potential mediators investigated were change at 6 months in attitudes towards self-management, fear of movement, self-efficacy for managing arthritis symptoms, body weight, physical activity, and at 6 months, unwillingness to have surgery. And these mediators were all measured via self-report, some with a questionnaire. So our method took 345 participants with complete data from the randomized controlled trial. All 6 potential mediators were considered for comparisons between exercise versus control, as well as diet plus exercise versus control. However, for diet plus exercise versus exercise, only change in weight was evaluated as a potential mediator. And then full causal mediation analyses were conducted separately for each mediator to estimate total direct and indirect effects, which are also known as the mediated effects, so the effects that occur through the mediator. So this involved fitting 2 regression models simultaneously using the paramed function in Stata, and each potential mediator and each relevant treatment group comparison were considered separately with adjustments made for the relevant baseline mediator and outcome, as well as the stratification variable in the original trial, which was history of knee surgery. So these variables were adjusted for as they were potentially confounders of the mediated outcome relationship. So this figure shows the results of the full causal mediation analyses for each potential mediator for the treatment group comparisons between exercise versus control at the top and diet plus exercise versus control at the bottom. The triangles represent the total effect of the first named treatment group, and the circles represent the indirect or mediated effects. So mediators of exercise versus control were, or appeared to be, reduced fear of movement and improved arthritis self-efficacy. And mediators of diet and exercise versus control were also reduced fear of movement and improved arthritis self-efficacy, but also weight loss, which accounted for almost 6 units of improvement in function. And what is not shown in the figure was that weight loss also appeared to mediate the effects of diet plus exercise versus exercise on change in function. And this accounted for approximately 4 units of improvement. And so weight loss was a mediator of the effects of both diet plus exercise versus control, as well as diet plus exercise versus exercise on change in function. So future telehealth delivered exercise programs with and without diet may benefit from targeting fear of movement and self-efficacy for managing arthritis symptoms. And in addition, exercise programs with diet may benefit from targeting weight as well. And the strength of this study was that we used full causal mediation analyses as opposed to the traditional Barron and Kenny method. And a limitation is that we did not account for potential interactions between mediators. So further research is required to verify our exploratory findings. And thank you all for listening. And I'd like to acknowledge the SSA BIC branch for their support to attend the conference.
Thank you, Fiona. Please join me in thanking Fiona for a great on-time presentation. I think you piqued our interest. If you've got any links to your work, just put them in the Slack, and I'm sure people will be interested to read that more. Thank you. All right, we have our next speaker for this session, Jaya, who's also from the University of Melbourne. When you're ready, Jaya, just share your screen. Sure. And when there's 1 minute to go, I'll shake my daughter's rattle and you'll know. Take it away.
Hello, everyone. My name is Jay Muller, and I'm a second-year PhD candidate at the University of Melbourne's Centre for Epidemiology and Biostatistics. Today, I'm going to quickly share my research on the estimation of parasite clearance rates for nosai malaria. Now, in recent years, Southeast Asia has seen... Sorry, can anyone see my screen?
Yes, that's fine. Yep.
Sorry, in recent years, Southeast Asia has seen a rise in Plasmodium nosai infections transmitted from macaques to humans via female Anopheles mosquitoes. Now, disease elimination here is impossible, but management is very important to prevent severe disease and deaths. Monitoring anti-malarial drug efficacy is crucial, and one key measure for it is the rate at which parasites are cleared from the human body. My study aims to compare 2 methods to estimate parasite clearance rates. The first being the typically used WARN or Worldwide Anti-Malarial Resistance Network Standard 2-stage, and the second that's rarely used, Bayesian hierarchical modeling. I'll refer to them as method 1 and method 2 respectively. Now, method 1 is divided into 2 stages. The first consists of fitting a regression model with a lag phase, a slope phase, and also a tail phase. The slope phase is what we're interested in, and this is applied to a patient's log parastemia profile. Now, the data used for the analysis is longitudinal with multiple parasite measurements taken at baseline and then every 6 hours post-treatment. Patients with less than 3 blood sample measures above the microscopic detection limit are actually excluded, potentially leading to selection bias in the second stage. Now, the second stage itself consists of calculating the estimated population mean parasite clearance and determining the effect of host or parasite factors on the parasite clearance. The second method is Bayesian hierarchical modeling, which estimates individual and population parameters in the model. The figure on the right depicts the typical multi-level Bayesian hierarchical structure, the distribution for the parasite density Yij for each patient I at time points j between 1 and t is determined by the individual level parameters, which in turn is determined by the population level parameters. Now, a change point model is used to determine the existence of the lag, slope, and tail phases within each patient profile. Covariates like treatment type, for instance, can be included simultaneously to investigate its impact on parasite clearance, and all patients are included in the analysis at once. However, the implementation of this method is more complex and time-consuming compared to method 1. Now, the statistical analysis was performed using R software version 4.1 and the BHRCR software package. So I used pooled data from 3 clinical trials conducted in Sabah, Malaysia, with 714 patients consisting of children and adults with uncomplicated or severe nosal infections. For results using method 1, we did not get a parasite clearance estimate for about 36 patients. It was a small percentage really, about 5%. And this was because there were too few parasite measurements, sorry. Visually, while many of the regression plots for method 1 had good or decent fits, overall method 2 definitely did better. The plots on the right are 2 examples of the model fits. Method 2 are the ones denoted by the blue lines. And you can see, especially between 0 to 10 hours, it does better than method 1, which is denoted by the red line. Now, analysis between the treatment types used was also done. It's quite evident that method 2 consistently overestimates the clearance rates compared to method 1. However, a direct comparison of the degree of bias for each of these methods could not be assessed, mainly because it requires a simulation study, which coincidentally has been done by Fogarty et al. In the context of Plasmodium falciparum malaria. There's one thing I'd like to point out, which is the chloroquine anti-malarial treatment, regardless of method used, has the lowest parasite clearance rate compared to the other treatment options. Now, to conclude, while Bayesian hierarchical modeling is the proper and most sophisticated statistical approach, there is no jarring difference between these methods, specifically in terms of drug efficacy. I would suggest using the standard 2-stage method for sample-rich data because it is quick and straightforward, as well as the fact that in the field, researchers may not have the statistical expertise nor the resources to use method 2. And then for scarce data, I would recommend using Bayesian hierarchical modeling because it does not omit any patient profiles. And that means you get some useful information about parasite clearance. I just want to quickly also just thank my supervisors for their guidance and support, as well as the clinical trials team for the data provided for the study, as well as a big thank you to the mini conference committee for giving me the opportunity to share my research, and to all the attendees for tuning in. Thank you.
Thank you, Jaya. Thank you for covering a lot of ground in what is not very much time. If you have any questions for Jaya, please go to the Slack channel, and I'm sure she'll be happy to continue the conversation there. Thank you, Jaya. Our next speaker is Phoebe. We've got a University of Melbourne trifecta. So also speaking on related to malaria. So Phoebe, when you're ready, just start sharing your screen and I'll give you the rattle when you got 1 minute to go.
Yep. So I'm not sharing now, am I? Yes, I am sharing. Can you see just the slides?
No, I think you need to swap the view around, I think.
Yeah. I think there should be a way to do it.
If you're in this, there we go.
There we go. Okay, great. Thank you. Yeah, so I'll also be talking about malaria today, simulating pediatric severe malaria populations to explore optimal dosing schemes. And this was a part of my Master of Biostatistics research project. So for treatment of severe P. falciparum malaria, the World Health Organization has recommended 3 milligrams per kilogram of artesunate for children weighing less than 20 kilos and 2.4 milligrams per kilogram for older children and adults since 2015. But in 2021, the American Food and Drug Administration, the FDA, challenged the status quo, and they instead advised 2.4 milligrams per kilogram irrespective of weight. And we think that this dose recommendation could lead to underdosing in younger children who already are disproportionately affected by malaria. So how do these dose recommendations come up generally? Well, they're based on simulated drug exposures, which just the drug levels achieved overall in the body. And these have been simulated in a virtual population using a pharmacokinetic model. And a PK model is a model that estimates typical drug concentration over time by taking into account the significant covariates that impact a drug's pathway in the body. So in the case of artesunate, this is weight and hemoglobin levels. And the figure here displays the PK model for artesunate, where the lines in the figure represent the median and the 25th and 75th percentiles for artesunate concentration over time. And the WHO and the FDA use the same artesunate PK model, but where they differ is how they modeled the covariates in their virtual populations to then derive those drug exposures. And I think how the FDA created their virtual population is problematic. So we know that to obtain realistic simulations of drug exposure, the virtual population needs to represent the target population, so children with severe malaria. But the FDA created a virtual population with weights and ages based on the children from the Center for Disease Control growth chart data. So these were American children. And you can see here that the children in the CDC dataset in grey weigh more than children with severe malaria in blue. So the FDA's virtual population weighs more than the target population. On top of that, the FDA created virtual hemoglobins in their virtual population, assuming hemoglobin was independent of age. But you can see here that in areas of high malaria transmission, younger children have reduced hemoglobin concentrations compared to older children. So again, the virtual population isn't matching the target population. So because I thought the FDA's method, virtual population, was flawed, and so there's their recommendation, I replicated some of their methods, but with better assumptions and better data to create a new and improved virtual population. So unlike the FDA, I incorporated the age dependency of hemoglobin for children with severe malaria, and I did this using the LMS method, and I captured a different relationship between weight and age based on a large data set of children with severe malaria instead of the CDC dataset, again using the LMS method. And once I had my virtual child population, I simulated artesunate exposures at different body weights using the PK model that both the FDA and WHO used with the different doses that they recommend. So here are my simulated artesunate exposures. The bottom graph shows them with the two different dosing schemes in red and black. So 2.4 milligrams per kilogram for everybody is the FDA endorsed dosing, and 3 milligrams per kilogram for children 20 kilos, and 2.4 otherwise is the WHO endorsed dose. The dots indicate the median, and the error bars are the 25th and 75th percentiles. And the dashed line is just the median exposure for children weighing 20 kilos as sort of a reference value. So basically, under the standard dosing that the FDA endorses, there's decreased exposure for children weighing around 8 to 18 kilos. And you'll notice that that is the weight range of most children who acquire severe malaria. So under the FDA's recommendation, most children who acquire severe malaria don't reach the same exposures as older children, and the WHO endorsed dosing lifts most children who acquire severe malaria to have comparable results. Very young children don't need the increased dosing, but there aren't any adverse effects from artesunate currently in the literature. So the WHO dosing, in conclusion, should remain, and the FDA should withdraw their dose recommendation. Thank you.
Thank you, Phoebe. That's really fascinating that you've got a federal body who's not basing their conclusions on representative data. Anyway, if you want to continue that discussion with Phoebe, I'm sure she'll be happy to go to Slack. Please join me in thanking all the 4 speakers, John, Fiona, Jay, and Phoebe, for what I think was a really great session. So we have a break now, and I think, yes, we're pretty much on schedule. So we'll have, let's say, a 7-minute break. So please come back for the final session for today. Thank you, everyone.